model in our mashra. So just you can go and see all the details present here. Okay. Mostly it is showing the relations of the duodenum with the pancreas and spleen. So when we begin with the structures of the midgut and hindgut, basically for today our lecture is the structures of the midgut and hindgut. So in this, we know already that the foregut, what structures will develop from foregut, what structures develop from midgut, and what structures develop from the hindgut. Do you remember this?
Yes.
Yes. So what are the structures developing from the foregut?
Livers, spleen,
Stomach
pancreas,
and liver.
stomach.
Yeah. Okay. You will start from the pharynx. Okay. Pharynx, oral cavity, right? Then it will give the respiratory bud, which will give the lower respiratory tract. Okay. Then esophagus. Then you have the stomach, liver, pancreas. Then the half of the duodenum means the half of the second part of the duodenum. Okay. Then for this we have the celiac trunk. Then from this half of the second part of the duodenum to ileum, jejunum, then cecum, appendix, ascending colon, okay, and the right two-third of the transverse colon. It will develop from the midgut, and their artery is the superior mesenteric artery. About the hindgut, so the left one-third of the transverse colon, descending colon, sigmoid colon, rectum, and upper half of the anal canal. And they have inferior mesenteric artery. Okay, so now if we do this section or if we open the abdomen, we will find that these are the intestinal loops, right? These are the loops of the intestine. But you will see there are some structure, okay, which has more of fat, okay, and it will be attached to the loops of the intestine anteriorly, and posteriorly it will be attached to the posterior abdominal wall. Okay, it is called as mesentery. Okay, so when you see mesentery, what is the definition of mesentery? That these are the folds of the peritoneum. Okay, these are the folds of the peritoneum, okay, which will enclose the coils of jejunum and ileum. So its anterior aspect, if you see this one, which is freely mobile, and posteriorly it has attachment to the posterior abdominal wall. Okay, so posteriorly it is attached border and it is 6 inches in length, and it is attached to the structures of the posterior abdominal wall. Okay, it extends from left side L2 to right sacroiliac joint. And what about the free border? So it is like the fan. Okay, you make the fan with the paper like the, so its posterior border will be narrow and the anterior border will be broad. Okay, 6 meter. You can see the difference. 6 inches posteriorly, 6 meters anteriorly free border, which will enclose jejunum and ileum. What you can see in the mesentery. Here you can see that this mesentery has some blood vessels. Okay, so it will have everything like fatty tissue, the mesenteric lymph nodes and lymph vessels, the nerve fibers, sympathetic nerve fibers. Okay, it will carry along with this. Here you can see it will carry jejunal and ileal branches, okay, which will be present between the two layers of the mesentery. Okay, and the superior mesenteric vessels, the coils of the jejunum and ileum, they are also enclosed into the free border of the mesentery. So these are the structures present in the mesentery. Now we will see about the jejunum. Okay, so jejunum, from where it will start? Okay, so the after the duodenum, the jejunum will start. Now we know now embryologically that it will occupy mostly the left upper part of the abdomen. Okay, so here you can see this is the left upper part, which is mostly occupied by the jejunum. Okay, so if we want to know if they are different in the feature, okay, they have some features by which you can differentiate. Okay, but it is not totally. Okay, there is slowly transition from the features of jejunum to ileum. So if you see, it will be about 2/5 of the small intestine. Okay, so if in living or in cadaver, if you try to feel the lumen, you will feel that jejunum, the lumen of the jejunum, it is wide and thick. Why it is thick? Because of presence of the fold. Can you see this is the open part? So here you will find there are many folds which will make it more thicker. So what are these folds called as? Plica circularis. Plica circularis. It has very few lymphoid tissues or lymphoid follicles. Its root will be above and to the left side of the abdominal aorta. Now the arterial arcades are simple and long terminal branches, and it will have a small amount of fat. Okay, so what does this mean by small arcades or large terminal branches? So now you can see this is the one of the main jejunal branch. Okay, so now it is not giving directly branches. Here you will find that it will make some arterial arcades, and then there are some terminal branches. Okay, so these terminal branches are longer in jejunum. Okay, if we compare this with the ileum, we will find that there are arcades more complicated. Okay, there were only just one line, but here you will find that there are more of the arcades are more complicated, and these terminal branches are shorter. Okay, here you will find these terminal branches are longer. And presence of fat. Then we have the ileum. So ileum, it is about 3/5 of the small intestine. And if you compare the lumen with the lumen of the jejunum, it is narrow. And if you open, you will find some lymphoid follicles, solitary lymphoid follicles. They are called as Baer's patches. And its root will be below and to the right side of the abdominal aorta. Its orchids are complicated with short terminal branches, and they will have large amount of fat. Okay, so here you can see these are the solitary lymphoid follicles, Baer's patches. Okay, these are the arterial arcades, which are more complicated with 2 or 3 layers, and the terminal branches are short. So this is the chart which is showing the important differences between the jejunum and ileum. So first of all, its length. Then if you compare the wall, you will find the jejunum has plica circularis, it has no or very few lymphoid follicles. But when you see ileum, very important, you will find the lymphoid follicles by which you can identify, by even you can see it with your eyes and also in the microscope histologically. Then the mesentery, if you try to compare, you will find that the mesentery of the jejunum is in the upper part of the abdomen, mostly to the left. But ileum, it is in the lower part and on the right side. The arterial arcades will be very simple and long terminal branches. In the ileum, the arterial arcades are complicated with long terminal branches. In jejunum, we have very few fat, and in ileum, there will be large amount of fat. Okay, so you will try to see the models we have. You cannot differentiate in the this specimen models, but you should know the differences. So now we have the large intestine. So the large intestine will start from, this is the ileum. So ileum will open into the cecum at the ileocecal valve. Okay, ileocecal valve. So the cecum, then we have the appendix, the ascending colon, okay, which will reach till the inferior surface of the liver, forming a flexure, right colic flexure or hepatic flexure. Then it will go transversely. It is known as transverse colon. Okay. Then again the transverse colon at the left side. Okay. With the in relation with the spleen, it will make one more flexure, which is called as left colic or splenic flexion. Then it will descend downward to form the descending colon. Finally, descending colon will give a S-shaped curve called as sigmoid colon. Then the sigmoid colon in the pelvic region, there will be continuation of the sigmoid colon as the rectum. Okay. So now this are the whole structure. Now, we will compare the small intestine with the large intestine. So, I think now you can make that, yes, exactly, there are some differences. Okay, so these are the coils of the small intestine and this is large. So, how you can differentiate here? We can differentiate the small and large intestine, or you will say there are some important features in which will be main characteristics of large intestine: tinea coli, circulations, and appendices epiploiky. Okay, so what are these? So first, the tinea coli. So do you remember what are the layers of the histologically layers of the GIT? Yes, anyone?
Yes.
Yes, please.
Mucosa,
Very good.
submucosa,
Mucosa,
Mucosa,
submucosa,
submucosa,
muscular
very good.
externa,
Muscularis
serosa.
externa, very good.
serosa.
Very good. So we have the four layers. What about the muscularis externa? How the muscles are arranged? Any idea?
Two muscles.
Circular and
Very good.
longitudinal.
Circular and longitudinal, right?
Yes.
Yeah. So what will happen in large intestine? The all the longitudinal muscles will make the three bends. Okay, in large intestine, these longitudinal muscles will be arranged in the form of three bands. Okay, like this. This one. Can you see this is one? Okay, like this. These are the longitudinal muscles which are arranged in band. So this is one band, this is another band, and there will be the third band. So these are the three bands of the longitudinal muscles which are called as tinea coli. And this is one of the most characteristic feature of the large intestine. Okay. So what do you mean by tinea coli? That the longitudinal muscle fibers, they are arranged in three bands. Okay. Tinea coli. Then the another feature, circulations. What do you mean by circulations? So if you see the large intestine and small intestine, the outside, the external feature, it is smooth, right? But in the large intestine, they are like the sac. Okay, they are making small sacs like this. Okay, so these are called as circulations or hospirations. Okay, They are called as seculations or hostrations. Okay, so like this, if I will make, it will be, these are the seculations. Okay, and this is one lumen. So here the longitudinal band means if you see the another part, you will find that this is the all the longitudinal fibers. It will be arranged like this in one band. Okay, so this band will be anteriorly maybe here. Okay, then posteriorly again you will have two bands. So these are the nothing but the longitudinal muscle fibers. Now we have another feature called as ependysis epiploiky. Okay, so what are this? Epiploiky, it means fat. Okay, so over the large intestine, you will find there are fat globules like this. Okay, so these fat globules are called as ependysis epiploiky or epiploic appendages. This one. So you will get many appendages like this. Can you see here? So you can see these appendages are in close relation with the tinea coli. Okay, so this is the tinea coli. Here you can see one, two, or one will be posteriorly. So these are the tinea coli. Okay, on which you have fat globules. They are called as the appendices epiploiky, and these are the seculations, which will make it, you can see one inside. This is the one, another band of the longitudinal muscle fiber, this one. Okay, so these are the three important different features. Now again, we have the another structure called as cecum. Okay, so what is the exact location for the cecum? It is right iliac fossa above the lateral half of inguinal ligament. Its diameter is about 7.5 centimeter. And if you see the peritoneum, so yes, it will be covered with the peritoneum, and this there will be some space between the peritoneum and the abdominal wall, which these are called as retroperitoneal recess. So what you will see here, can you imagine what will be there? Okay, so it is lying in the pelvic cavity. Yes. So what organs or what structures will be there? Behind we have one figure here. Okay, so here you can see this is the iliacus muscle, right? You remember this picture, the posterior abdominal wall. We have the one model also, which is showing all these pictures or all these structures. So this is iliacus muscle. Then we have the transverse abdominis muscle. Okay, here we have the psoas muscle. Okay, this one is the transversus abdominis, right? Okay, this will be the psoas muscle which will come here to insert over the femur bone. Okay, here this is the quadratus lumborum. Okay, just I'm giving you few orientation. This is the quadratus lumborum, transverse abdominis, iliacus, and then this is psoas. Okay, and this is the area for the cecum. So here you can see that it is related with two more important nerves, in which this is the femoral nerve, right? And this is lateral cutaneous nerve of thigh. Okay, lateral cutaneous nerve of thigh and femoral nerve. Okay, so above we have another nerves. This we will see later. But at this point of time, you should know iliacus, psoas muscle. Okay, then these two nerves. Okay, so we have this right psoas major muscle, right psoas muscle, right iliacus, right lateral cutaneous nerve of thigh, and right femoral nerve. These are related posteriorly. So what is the nerve supply? This is the interior of the cecum. If you open cecum, you will find that there are two openings. Okay, one, it is called as ileocecal valve. Okay, the another opening, which is just below this is the for appendix. Okay, you can see there is the another structure which is continued, which is appendix. What is the artery of this, or which arteries will be supplying? So now we know which major artery is going to supply, because this is the structure of the midgut. So we will have the superior mesenteric artery. Okay, but now you should know the specific branches. So these are the anterior and posterior cecal arteries from the ileocholic artery. Okay, very easy. Cecum, so anterior and posterior cecal arteries, and they are coming from where? From the ileocholic artery. Ileocholic artery is coming from where? From the superior mesenteric. Now we have the next organ, that is the vermiform appendix. Okay, we will see that this is the very small vestigial organ which has no function, right? But this is one of the very notorious organ which is responsible for acute abdomen or acute abdominal pain. The appendicitis, it is one of the commonest cause for acute abdominal pain. Okay. So what is the exact location, anatomical location? It is attached to the posterior medial surface of the cecum. Okay, 1 inch below the ileocecal wall or ileocecal junction. And this appendix has not only one position, okay? It has different positions, okay? Like it could be retrocecal, okay, which is one of the common position. Then it can be into the pelvis against right pelvic wall, okay? As we told, it is posterior medial, so it can be over the lateral side, okay? It may be in front of the ilium or behind the ilium, okay? So in which the commonest site are the retrocecal and pelvic. Okay, and its length is 0.5 to 9 inches. It is normal, and sometimes its length is more, which is also one of the cause for the inflammation and acute abdominal pain. It will be completely covered with the peritoneum. Okay, and here it is called as mesoappendix. Now we all know that the pain of the appendicitis, generally it will refer to which area? Yes, any idea? The pain of the appendicitis, it will refer to?
Umbilical region.
Very good. Umbilical region. Why?
Because the somatic structure is related to the umbilical skin.
Yeah, so now you should know that because they both have the T10 or 10th intercostal nerve supply. Okay, because this both area, this appendix and the skin over the umbilicus, they both are supplied by the T10th, or you can say 10th intercostal nerve. Okay, so this is the reason that the pain will be referred to umbilical region. So here you can see different positions and the location of the appendix, and this is mesoappendix. Okay, just now we saw that this is the hold of peritoneum. Again, we have different positions, okay? So this is the ilium, so it could be pre-ilial, in front of the ilium, post-ilial, okay? This is the pelvic, okay? This is the retrocecal, which is very common. It is posterior medial to the cecum. It could be below the cecum, subcecal. Okay, so these are the different positions. Now, if you want to locate the appendix on your body surface, how you will locate? Okay, so you have the important point called as McBurney's point. where you can locate the base of the appendix. So how you will locate? You have to draw a line joining the umbilicus with the anterior superior iliac spine. Okay, from umbilicus to anterior superior iliac spine. Okay, obviously towards the right side. So when you join this line, so from the medial, at the junction of the medial 2/3 and lateral 1/3, this point, it is called as McBurney's point. Okay, this will be the base of the appendix. And at this point, if you, while doing examination, if you will check for tenderness, at this point, there will be maximum tenderness in appendicitis. Okay. So just don't forget, this is very important, how you can locate the appendix in the on the abdomen. So you have to say this line and this point. What is the blood supply? So it will be supplied by appendicular artery. From where appendicular artery will come? It is the branch from the posterior cecal artery. Okay, so we have the next organ, the ascending colon. It is about 13 centimeter and it is present in right lower quadrant. So what is the extent? Just now we already have seen that it will ascend upward towards the inferior surface of the liver, from where it will just make a flexure and go into the center. Okay, it will be covered by the peritoneum. Yes, it will be covered in front and on the sides. Okay, it will be having the tinea coli as we have seen. All the parts of the colon will have the tinea coli, okay, which you can see here, one anteriorly and two posteriorly. Okay, what will be the posterior relation? So now you have seen already the picture that it will have the iliacus muscle, iliac crest, quadratus lumborum, transverse abdominis, lower pole of right kidney, and iliohypogastric and ilioinguinal now. Okay, this I will show you later. What is the arterial supply? So again, it will be supplied by the ileocholic and right cholic branches. Okay, so ileocholic and right cholic branches from the superior mesenteric artery. So next we have the right cholic flexure. So where is the location for the right cholic flexure? So obviously it is between the ascending and transverse colon. It will make 190 degrees acute angle. Okay. And it will be covered with the peritoneum from front and side. What will be posteriorly? Right kidney. Anteriorly we have the liver. Now here if you compare, you will find the left cholic fracture is going more upwards. Right is little lower and left is little in the superior surface, superior area. Then we have the transverse colon. So the transverse colon, now we know all the history about the transverse colon, that it has developmental variation, even it has the different arteries, right? So it will be present between the right and left cholic fracture. Okay, the right part, if you see, it is retroperitoneal, but the left part, it has the covering which is called as transverse mesocolon. You remember the transverse mesocolon? Yes? Have you heard the
Yeah.
transverse? Yeah, so another
Yes.
part of this transverse mesocolon will be attached to the one part, or one end is attached to transverse colon. What about the another end? Which organ? Idea? Any idea?
Pancreas.
Very good. Very good. Okay, we will see again. So anteriorly, if you see, if you remember, we have a model. So as soon as you open the anterior abdominal wall, you can see that very nicely that there is a greater omentum and transverse colon. Okay, so anterior relation, anterior abdominal wall, greater omentum. What about the posteriorly? So posteriorly, we will have the second part of duodenum, head of the pancreas, and coils of jejunum and ileum. Okay, so just in Mashra, just try to see, we have all these structures very nicely, you can see. So you have cut open the transverse colon. So here you can see duodenum and head of the pancreas, this one. Okay, so this is the second part of the duodenum. This is the head of the pancreas. What about the arteries now? So we know the proximal 2/3 will be by the middle colic artery, which is a branch from superior mesenteric artery. And distal will be by the left colic artery, which is a branch from inferior mesenteric artery. What about the left colic fracture? So it is about the right angle between the descending and transverse colon. And it is connected to the diaphragm by a fold of the peritoneum, which is called as phrenico-colic ligament. Okay, don't forget that the left colic flexure or splenic flexure, it will be attached to the diaphragm by the phrenico-colic ligament. Okay. What are the posterior relations? Obviously, it has diaphragm posteriorly and anteriorly it has spleen. Now this is the descending colon. So it will start from the left colic flexure till the pelvic brim here. Till the pelvic brim. And here it will become the sigmoid colon. Okay. And it has peritoneum which will cover it from the front and sides. What will be the posterior relation? So same as we have seen in the ascending colon. So it will include whole of the this one. So here you can see this is the, so here we will have the transverse abdominis muscle. We have the psoas muscle. Okay. Then we will have the part of the iliacus. Actually, iliacus here it will be more related with the sigmoid colon. Then we have the nerves. Which nerves? You can see here iliohypogastric, ilioinguinal. Okay, iliohypogastric, ilioinguinal, and we have already seen this is the lateral cutaneous nerve of thigh, and this is the femoral nerve. Okay. Then in the above, if you see upper part, in the upper part you have the lower pole of the kidney, and here you will have the subcostal nerves and vessels. So these are the relations, posterior relations. Then what about the artery? Yes, it will be supplied by the left colic and the sigmoid branches of inferior mesenteric artery. Okay, so these are the relations. So this is the picture. So if you remember, we have seen the first slide, that mesentery, attachment of the mesentery. So if you remove whole of the small intestine, this picture will appear. This is the posterior attachment of the mesentery. Okay. Now, what else you have to see here? When you remove this, okay, when you remove the small intestine, okay, now we have seen that the mostly the large intestine is discovered from the peritoneum, from the front and side. So can you see there are spaces between the this colon and the abdominal wall here. Okay, and here also you will find that there is a space between the medial border and the mesentery. Okay, here also you can see the space between the ascending colon and the abdominal wall. Okay, so what are these? These are called as paracolic gutters. Okay, these are called as paracolic gutters because these are on the sides of the colon. Okay, so these are on the lateral and medial sides of the ascending and descending colon. Okay, so on the right side, you will have right medial. Where will be right medial? Here. Okay, so here you will have the right medial, okay, left medial, right? Then this will be the right lateral, then left lateral. Okay, so what about the right medial? If you see, it is closed. Okay, this space is closed. This space is closed. Okay, then what about the left medial? Yes, this is also closed. But if you see the right lateral, this one, you will find that it is in communication with the liver, with the subphrenic space. This is the subphrenic space because it is below the diaphragm. Okay, and then if you see the left lateral, it is separated from the area of the spleen by the phrenicocholic ligament. You remember just now we saw that there is a phrenicocholic ligament, okay, which is between the colon and the diaphragm. This one, this is the phrenicocholic ligament. Okay, so it is separated from the area. Here we will have the spleen. Okay, so this is the phrenicocholic ligament. So now here you can see mostly which space is more open, or you can say which is more in communication, this one. Okay, the right lateral paracolic gutter. Okay, so why it is important to know? So if there is any inflammation, or if there is any abscess of the liver, or if there is even something related with the lungs, if there is any inflammation from the lungs, so it may reach to this area, and finally it may reach to this area, and finally it may reach to the pelvic cavity. Okay, so this is the open space. Mostly you will see these medial spaces are closed. Okay, and also here you will have the ligament, but this space is open. Okay, so if you want to drain the abscess from this area, this is the position you will give. You will ask the patient, or you will ask the patient to lie in this position. So this is the best position to drain any abscess, any phrenic or the paracolic abscess from the paracolic gutter, like this. Okay, so finally it will go into the pelvic cavity, it will get absorbed, and it can be drained from this area. Then next we have the sigmoid colon. So from where it will start? It will start from the pelvic brain as the continuation of the descending colon. Where it will finish? It will end at the third piece of the sacrum and continue as the rectum. What are the relations? So yes, it also has peritoneum. It is completely covered, and this peritoneum or this mesentery here, it is called as mesocolon. Can you see? This is sigmoid mesocolon. It is inverted V shape with apex and two limbs. This is the apex and these are the two limbs. And in this sigmoid mesocolon, you will find the sigmoidal branches from the inferior mesenteric artery. Generally, they are from 4 to 5 branches. So again, this is the again repetition for the blood supply. Okay, so what is the origin for the celiac trunk? It is from the 2T12. What is the level of origin of superior mesenteric artery? L1. Inferior mesenteric artery? L3. You remember this? Have you seen? We have the model like this.
Yes.
Are you with me?
Yes, doctor.
Yes, okay. So
Yes,
now we
doctor.
know. Yeah, thank you. So yeah, now you know these are the three main arteries. So additional information that what is the level of origin? So celiac from T12, superior mesenteric L1, inferior mesenteric from L3, this one. So I hope now you understood the main Okay, so what here I want to tell you. So artery is clear, everyone? Okay, so just this is superior mesenteric artery. Okay, so what is happening to the superior mesenteric artery? Okay, what main branches it has given here? Ileocholic. Okay, right colic. What has happened to the ileocholic? So you will trace the ileocholic and you will find that it will give the sickle branches, anterior sickle and posterior sickle. Okay. Then after that, it will give the branches to the ascending colon. Okay. So ileocholic means it is going to supply some part of the ileum, of course, because the ileum, it will also develop from the midgut. So first artery is our ileocholic artery. So it will give ileal branches. Okay, so it will give ileal branches. Then it will give branches to the cecum. Okay, this is cecum. What branches? Anterior and posterior cecal arteries. In which from the posterior cecal artery you will get the appendicular or branch for the appendix. Then we have the number 2 second artery, which is the right colic artery. So right colic artery, this is number 1. This is number 2. So right colic artery is supplying what? This is also supplying the ascending colon. Okay. Then we have the third branch that is called as middle colic artery. Okay. So this is the middle colic artery. So you will find that middle colic is also supplying to the right part of the transverse colon. Okay. And it is giving branches towards the ascending colon. Okay, so clear here what main branches you have seen? The ileal branches, then ileocholic, right colic, and middle colic. Clear? Okay.
Yes.
Yes, it's
Then,
clear. Yeah.
then we have the another important artery, which is the artery for the hindgut. So here it is inferior mesenteric artery. Okay. So you will see that there is one important branch here, which is called as left colic artery. Okay. So you will find that this left colic artery, okay, this is the left colic artery, which is going to supply the remaining part or the left 1/3 of the transverse colon. Okay. Then it is going to supply the descending colon. Okay. Then again, we can see another arteries. These are the sigmoid arteries. As I told you, sigmoid artery is not only one. It will give small 3 to 4 branches, in which some branches will also supply the descending colon. Okay, and it will also supply the here sigmoid colon. Okay, then finally, what is there? You will see that this is the inferior mesenteric artery. So after supplying all the structure, it will continue downward as the superior rectal artery. Okay, so the inferior mesenteric artery will continue downward as the superior rectal artery. Clear? At least you got the basic idea. The right and middle colic artery, they are from the superior mesenteric artery. But the left colic artery, it is a branch from inferior mesenteric artery. Okay. So now can you see here all these arteries, if you say any right colic, ileocholic, left colic, they are making us like this a margin. Okay, all the arteries are they are anastomosis with each other. You will not say, or you cannot say that right is going to supply only this area or left is going to no. They are anastomosing with each other. Okay, so this artery, which is like making a convex shape circular in the shape of the large intestine. This is called as marginal artery. Okay. So what is the marginal artery? This is the anastomosis of the colic arteries. Okay, around the concave margin of large intestine. Okay, so this single trunk, okay, this single trunk like this is called as marginal artery. Okay. So inshallah, you will have again the details of the arterial supply. And the maybe you will have separate lecture for this, but this is the basic concept. You should know about the small and large intestine, the nerves, the arterial supply. The next organ we have the rectum. So it will start from the S3, okay, as the continuation of sigmoid colon. Okay, and where it will finish? So at the tip of the 1 inch below the tip of the coccyx, it will become the anal canal here. And anatomically, if you will see, it is not straight. Okay, it has three lateral curves like this. Okay, and it has a dilatation which is called as this is the rectal ampulla, and these are the lateral curves. Again, this is the section. So in this section, if you remember, we have this section like this. So here you can see, okay, the rectal ampulla, the dilated part, and this will be the curves. So is it different from the another part of the colon? Yes. So we know that there in the colon we have the tinea coli, but what will happen here? In the rectum, this longitudinal muscle bands will not be three. Now it will become only two. So you will not call them tinea coli. They are called as two longitudinal bands which will be present anteriorly and posterior. So you will have the anterior band and posterior band. Okay. So in the mucous membrane, you will get the longitudinal folds and semilunar folds. So what are these semilunar folds? Like this. This semilunar folds. So the rectum is covered with the peritoneum. Yes, it has covering in the upper part. It will cover in the front. Okay, and also the sides. Okay, in the middle part, you will see it is covered only in the front, no at the side. Okay, and the lower part, there is no peritoneum. Okay. What are the relations? So it is very easy. We have seen many times that in the male, it will be related anteriorly with the coils of the small intestine, sigmoid colon. Then here we will have the bladder. Okay, this is called as rectovesical pouch. Okay, the posteriorly there will be the sacrum. Okay, and the muscles attached to it. What about the female? So in female, you have very important rectouterine pouch. And another name for this is the pouch of Douglas. You remember this? What is the arterial supply? So it is little complicated, or you will say you have three arteries. Okay. Superior rectal artery, middle rectal artery, and inferior rectal artery. But if you see the source of or origin of these three arteries, all are from different sources. So superior rectal artery, it is a continuation from the inferior mesenteric artery. Okay, and it will supply the mucous membrane. Middle rectal artery, it is the branch from the internal iliac artery. Okay, and it will mainly supply the muscular core. And inferior rectal artery, it is coming from the internal pudendal artery. Okay, so you must know that there are three arteries with the three different sources. What about the veins? So here you can see superior rectal, middle rectal, and inferior rectal. Okay. Then what veins? The veins will be along with the artery, superior rectal, middle rectal, and inferior rectal vein. Okay, the lymph, yes, it will be from the superior rectal lymph nodes, middle rectal, and inferior rectal lymph. So what you can feel, which organs you can feel if you do the per rectal examination. This is called as digital per rectal examination. Okay. So what organs you can feel here? Yeah, what is this?
Prostate.
Very good. So this is the prostate. So you can feel the prostate. You can even feel the posterior border of the urinary bladder. Okay, if there is any problem here. So in digital rectal examination, first of all, you can see the prostate. Okay. Then you can see posterior surface of the urinary bladder. Then you can see or you can feel the contents of rectovesical pouch, if there is any mass or is there any accumulation of the fluid. Okay, the seminal vesicle, urogenital diaphragm, and perineal body. Do you remember perineal body and urogenital diaphragm here? It will be here. So you can feel these structures in which if there is any enlargement in the prostate. Okay, in female, basically you will find this pouch. What is this pouch? Yes?
Douglas pouch.
Yeah, very good. Pouch of Douglas or rectouterine pouch. Okay. And here, uh, the surgeon can feel the vagina, cervix, urogenital diaphragm, and perineal body. Okay. So by this digital rectal examination, the surgeon can feel these structures, can feel the consistency, if it is a solid mass or if there is any liquid or is there any enlargement of this organ. Okay. Okay, thank you so much. So this is also we have the model like this. So in Mashra, you will try to find out all the structures. Okay, so any questions?